Good day. I am Dr. Resti Bautista, and this is a photo of my newborn son taken almost 13 years ago. Our topic for this session is the newborn. I have provided a self-instructional handout on patterns of growth, nutrition, and development of the newborn to supplement this lecture. The objectives of this lecture are the following. First, we will define the newborn period. Then we will strive to understand the changes of the transition period from in utero to extrauterine life. Then we will understand the immediate needs and care of the newborn as outlined in the Unang Yakap or Essential Newborn Care. We will also understand obtaining history and performing physical examination of the newborn, including conduct of the neurodevelopmental exam. And lastly, we'll understand normal infant feeding behavior, especially the amazing capabilities of the newborn for breastfeeding. Human development begins after the union of male and female gametes during a process known as fertilization or conception. The human embryo, who is a human being, begins at fertilization, and the embryonic period ends by the end of the 8th week, when the fetal period begins. The human fetus exists in a unique environment that provides for gas exchange, warmth, protection, hydration, and nutrition. Throughout the 40 or so weeks of gestation, the fetus is exposed to various stimuli, including sound, smells, and flavors, and exhibits movements such as breathing, swallowing, flexion and extension, and thumb sucking. It has been proposed that these experiences in utero lay the groundwork for future organ function, and fetal memory prepares for acquisition of important survival skills of the newborn. For example, fetal breathing movements are observed beginning 10 to 11 weeks of gestation. The fetus also has eye movements that correlate to REM and non-REM sleep. Exposure to the tone and cadence of the mother's speech as well as her heartbeat may factor in later in acquisition of language. The fetus also experiences different flavors and smells of the amniotic fluid due to the influence of the mother's diet, which allows the newborn to identify their own mother's breast milk. The newborn or neonatal period is from birth to the first 28 days of life. In the next few slides, we will understand the changes of the transition period from in utero to extrauterine life. These normal and rapid changes, especially in the function of the lungs and heart, need to occur within the first 30 seconds to 1 minute of life. In the fetus, the pulmonary arterioles are constricted and the pulmonary blood flow is diminished, and blood flow is diverted across the ductus arteriosus.
Because of the constricted blood vessels in the lungs, most of the blood bypasses the lungs and instead passes into the aorta via the ductus arteriosus.
After delivery, the lungs expand with air, the fetal lung fluid leaves the alveoli, and the pulmonary arterioles dilate with an increase in pulmonary blood flow.
Fluid in the alveoli is absorbed into the lung tissue and replaced by air. The oxygen in the air diffuses into blood vessels and surrounding alveoli.
The blood oxygen levels then rise, with subsequent constriction of your ductus arteriosus, and blood now flows continuously through the lungs to pick up oxygen.
As blood levels of oxygen increase and pulmonary blood vessels relax, the ductus arteriosus begins to constrict. Blood previously diverted through the ductus arteriosus now flows through the lungs, where it picks up more oxygen to transport to tissues throughout the body.
These major changes take place within seconds after birth. Fluid in the alveoli is absorbed, umbilical arteries and vein constrict, and blood vessels in the lung tissue relax. Problems may arise if these important transitional events do not occur. In the next few slides, we'll be discussing the immediate care after birth, how to address the immediate needs of the newborn in the first hour of life. These immediate needs include the need to breathe, to be warm, to be protected, and to be fed. The goal for any newborn is to provide a continuum of care as provided by the uterus for the fetus. So at birth, the newborn needs to breathe to establish normal ventilation and oxygenation. The newborn also needs to remain warm and avoid the harmful effects of hypothermia. The newborn needs to be continuously protected from a potentially harmful environment. And lastly, the newborn needs to be fed. Breastfeeding needs to be initiated within the first 60 to 90 minutes of life. Since the transitional changes are time-bound, we require an accurate recording of events. So first step is to call out the time of birth. Then we thoroughly dry the baby with a warm, clean towel or cloth and check breathing. And don't forget to remove the wet cloth. Maintaining thermoregulation requires prevention of heat loss, and this is mainly from evaporation of the amniotic fluid from the skin surface. Other forms of heat loss are conductive, from contact with a wet cloth or cold air, and radiative, for example, being adjacent to a cold wall. Ideally, keep the room temperature at 25 to 28 degrees Celsius, and we must minimize air drafts in the room. We then do a quick check of breathing and tone while we are drying the baby. We check for regular and easy movement of the chest as the newborn inhales and exhales. A vigorous crying baby is a breathing baby. For a term newborn, the resting posture is flexion of the extremities, with the extremities closely adducted to the trunk. The baby is delivered onto the mother's abdomen in skin-to-skin contact, providing natural warmth from the mother's body. We cover the baby's back and head to prevent exposure to cold air. We clamp and cut the umbilical cord in a sterile manner after the pulsations have stopped, which is in at least 30 seconds, but this usually takes 1 to 3 minutes. During this time, the normal umbilical cord will continue to provide oxygenated blood from the placenta, which aids the lungs and heart as they transition to extrauterine function. We then allow uninterrupted skin-to-skin care and initiation of breastfeeding. We initiate breastfeeding within the first 60 to 90 minutes of life when the newborn exhibits appropriate feeding cues. We postpone these other important activities such as weighing, administration of vitamin K, vaccination with hepatitis B and BCG, performance of eye prophylaxis, and a full physical exam until after the first breastfeed has been completed, usually after 90 minutes. What we have just described are the core steps of early and essential newborn care. 1. Immediate and thorough drying. 2. Early skin-to-skin contact. 3. Properly timed cord clamping. And 4. Non-separation of the newborn from mother for early breastfeeding. The standard approach should be to treat mothers and their newborns as an inseparable unit. And the management of the third stage of labor and delivery of the newborn must be performed in a time-bound, stepwise, and coordinated manner. There will be a separate lecture to expound further on the rationale and benefits of these 4 core steps of what we now call early essential newborn care, or our unang yakap. Let's now discuss history and physical examination of the newborn. Clinical history of the newborn is ideally obtained prior to delivery with a thorough review of the perinatal history. This is conducted either through interview with the mother or family or via discussion with her obstetric healthcare provider. The main goal is to assess risk for any neonatal problem and therefore anticipate and prepare for the delivery. Interval history pertains to the period after birth until the time that you are assessing the neonate. We discuss with parents the main activities of their newborn: breastfeeding, stooling and urination, crying and sleep, as well as perform a standard review of organ systems. The majority, but not all, of newborn problems can be anticipated by identifying the presence of antepartum and intrapartum risk factors, especially those associated with the need for neonatal resuscitation. The absence of risk factors predicts but does not guarantee the birth of a normal newborn. The first thorough physical exam is done after the newborn has completed his or her first breastfeed. For a thorough discussion, please refer to your textbook, Nelson's, and our local Fundamentals of Pediatrics. Techniques of physical exam in the newborn rely primarily on inspection, with some auscultation and minimal palpation. Rarely do we utilize percussion in the neonatal exam. It is important to know the normal range of findings and routinely check for birth injuries as well as unusual fasces or malformations. And you must learn to recognize severe malformations and patterns of malformations. The assessment of intrauterine growth will rely on accurate measurements of weight, length, and head circumference. Intrauterine growth can be categorized according to gestational age. If the birth weight is less than the 10th percentile or more than 2 standard deviations below the mean of a population-specific weight versus gestational age plot, then that newborn is designated small for gestational age, or SGA. If the birth weight is above 90th percentile, the newborn is designated large for gestational age, or LGA. The rest are categorized as appropriate for gestational age. Intrauterine growth can also be categorized by birth weight. Those weighing less than 2,500 grams at birth are labeled low birth weight. Those less than 1,500 grams are very low birth weight, and those weighing less than 1,000 grams are extremely low birth weight. Let's now watch this video of the newborn exam.
Welcome to the Learn Pediatrics module on the newborn exam. In this module, we'll be reviewing the examination of the newborn. We do this exam just after birth, prior to discharge from hospital, and at regular intervals throughout the first few months of life. Initial examination of the newborn should be done as soon as possible after delivery. This ensures early detection of any abnormalities and establishes a baseline for subsequent examinations. As with all physicals, it is important to properly position both yourself and the patient. For the newborn exam, you should ensure that the ambient temperature is warm enough to allow for the infant's comfort while being exposed. Often, keeping the entire room warm is difficult. Using an examining table with a built-in warmer is quite useful. While having a routine order of procedure in the examination of the infant makes less likely the omission of any essential part of the examination, your routine should be flexible. If the infant is quiet and relaxed when first approached, auscultation of the heart and palpation of the abdomen can precede more disturbing examinations, such as the mouth and hips. At the time of delivery, the infant's APGAR score should be recorded. The components of the score are color, heart rate, reflex irritability, muscle tone, and respiration. It should be documented at 1 and 5 minutes after birth. If the 5-minute APGAR is less than 9, further recording should be made at 5-minute intervals until the newborn is clinically improved. Once you've determined that the baby is stable, from an airway, breathing, and circulation perspective, you can begin your systemic exam. It's important that a few exact measurements be made and recorded. These include weight, crown to heel length, and head circumference. These should be plotted on an appropriate centile chart on each visit to allow for early identification of growth problems. Note how active the baby is, and whether the baby's cry is normal. Look for any obvious malformations, dysmorphic facies, or limb abnormalities that may suggest a serious syndrome, such as trisomy 21. Take note of the baby's respirations and effort of breathing. Grunting or labored breathing usually suggests pulmonary pathology, such as respiratory distress syndrome. Most often, the breathing of a newborn is diaphragmatic, so during inspiration, the anterior thorax usually draws inward while the abdomen protrudes. Pay attention to the baby's color. See if there is any pallor, plethora, jaundice, or cyanosis. Acrocyanosis, where the fingers and toes appear bluish, is normal for a newborn infant. If there's generalized cyanosis, observe the response to oxygen administration as well as what happens during crying. In the absence of cardiac disease, the infant should spontaneously pink up over time, or with positive pressure ventilation. Very few babies need resuscitation, often just drying, positioning the baby properly, and patience is all that is needed for the infant to breathe and move spontaneously. If more active resuscitation is needed, follow current NRP protocols. In this section, we will go through the newborn examination from head to toe. Skin. Besides the color of the skin, there's some common skin changes or manifestations that you should look for. When the infant is delivered, it is often covered in a cheesy, white covering called vernix. This is completely normal. Occasionally, you may see milia, which are pinpoint white papules on the face that are keratin-filled epithelial cysts. These resolve spontaneously. Look for slate gray patches, which are also known as Mongolian spots. These are bluish patches, usually located on the lumbar and buttock areas. They are commonly found in babies with darker skin. They are normal and become less obvious over time. Birthmarks, such as hemangiomas, salmon patches, and small café au lait spots, are found on most neonates. Rarely, the presence of numerous or large birthmarks may necessitate an expert dermatologic opinion. The most common rash seen on newborns is a papular eruption known as erythema toxicum. This usually appears on day 2 or 3 of life. It resolves spontaneously and requires no treatment. Note Any petechiae or bruising of the face, which may indicate a traumatic delivery. This can place the infant at higher risk for neonatal jaundice. Head. The infant's head is often molded at birth from being engaged in the vaginal canal. It's not uncommon for the skull bones to overlap each other. Palpate the anterior fontanelle, coronal, sagittal, and lambdoid sutures, and posterior fontanelle. Take note of any trauma to the head, such as caput sexadeum, which is the diffuse swelling crossing suture lines caused by pressure from the uterus or vaginal wall during a vertex delivery. Cephalohematomas, bleeding into the periosteum that does not cross suture lines, may also occur. More concerning would be the presence of a subgaleal hematoma, a fluctuant boggy mass that is movable over the entire scalp. These bleeds are rare, but because bleeding is into the large potential space between the scalp and the periosteum, a large volume of blood can be lost from the circulation. The eyes are most easily examined if opened by the baby itself. This often occurs spontaneously if the eyes are shaded from light with hands or during feeding. Shine a light to elicit the red reflex. Absence of this may suggest congenital cataracts or other intraocular pathology. Look for dysmorphic features such as the presence of a flattened bridge of the nose, facial asymmetry, or epicanthic folds. Choanal atresia is checked for by seeing if the infant can breathe with mouth closed, and then with left and right nostril occluded alternately. If in any doubt, check nasal airways with a catheter. Infants are obligate nose breathers till 4 months of age. Ears, which are unusual in size or shape, are floppy or lacking in normal cartilage, and especially if low placed, are of significance and may be associated with urinary tract abnormalities. Universal hearing screening is recommended for all infants using formal audiological testing modalities, such as automated auditory brainstem response or evoked autoacoustic emissions. The mouth should be fully inspected with a good light and spatula, and the palate inspected right back to the uvula to exclude minor degrees of cleft palate. Sternomastoid muscles should be palpated and the range of rotation of the head to each side checked to rule out congenital torticollis. Palpate the clavicles for fractures. Webbing or redundant skin in a female infant suggests intrauterine lymphedema and Turner syndrome. Chest. Moving down to the chest, look for any asymmetry of the rib cage. Breast hypertrophy is common in males and females due to transfer of maternal hormones. Listen to the chest to ensure equal air entry to both lung fields. Crackles may indicate infection, respiratory distress syndrome, or transient tachypnea of the newborn, particularly in a baby who is born by cesarean section. Listen for heart sounds and murmurs on both the chest and the back. Transient murmurs are common and often benign. On the other hand, congenital heart defects initially may not produce any abnormal heart sounds. Brachial and femoral pulses should be palpated and their strength and timing compared. Absence of femoral pulses or brachiofemoral delay is suggestive of left-sided heart lesions and coarctation of the aorta. It takes practice to feel the femoral pulses. They should be felt using gentle pressure over the inguinal area. Abdomen. Inspect the abdomen for any obvious defects. The umbilical cord should have 3 vessels, 2 arteries, and 1 vein. Finding a variation from this should prompt formal renal assessment by ultrasound. The abdominal wall is usually weak, especially in preterm infants. Therefore, diastasis recti and umbilical hernias are not uncommon. A scaphoid abdomen suggests diaphragmatic hernia, while abdominal distension suggests obstruction, often due to meconium ileus. Following inspection, palpate for internal organs. The liver is normally palpable as much as 2 centimeters below the costal margin. Less commonly, the spleen tip may be felt. The kidneys, especially the right, can often be felt on deep palpation. Genitalia. Now we will move on to the genital examination. Inspect that the infant does not have ambiguous genitalia. In a newborn female, the labia majora are prominent. Non-purulent discharge is a normal phenomenon. A whitish or pinkish red discharge can be present secondary to transfer of maternal hormones. Ensure that there is no clitoromegaly, that is, the enlargement of the clitoris beyond 1 centimeter in size. In the male infant, the normal scrotum is relatively large. Both testes should be descended into the scrotum. Any scrotal swelling can point to the presence of a hydrocele or hernia. A penile length of less than 2.5 centimeters is indicative of micropenis and should be investigated. The prepuce of the newborn is normally tight and adherent. An erection of the penis is common and bears no significance. Most infants void within a 12-hour period, and by 24 hours, 95% of newborns will have passed urine. Check that the anus is in a normal position and is patent. An imperforate anus is not always visible and may require evidence obtained by gentle insertion of the little finger or a rectal tube. A sacral dimple caused by an irregularity of a skin fold is often present in the sacrococcygeal midline and may be mistaken for an actual or potential neurocutaneous sinus. Concerning features would include a dimple that is higher on the back than the tip of the sacrum, tufts of dark hair overlying the dimple, or actual visualization of a fluid-filled meningocele. Meconium should be passed within the first day of life. Passage of meconium beyond the first 24 hours of life warrants investigation. Musculoskeletal. In examination of the musculoskeletal system, deformities observed in the infant are often due to the way the fetus was positioned in utero, or due to the presentation and trauma of delivery itself. Spontaneous symmetric movements of the extremities should be observed. Absence of this may indicate nerve damage or fractured bones. Hands and feet should be examined for polydactyly, syndactyly, and abnormal dermatoglyphic patterns, such as a single palmar crease. The feet should be examined for evidence of talipes equinovarus or club foot, where the feet are permanently inverted at the ankles. A large gap or deep crease in between the first and second toe can indicate possible Down syndrome. The hips of all infants should be examined with specific maneuvers to rule out congenital dislocation. In the Barlow maneuver, the hips are flexed and the thighs adducted. Apply force posteriorly in line of the shaft of the femur in the attempt to dislocate the femoral head from the acetabulum. Dislocation is confirmed by the Ortolani maneuver, where the dislocated hip is reduced back into the acetabulum. The hips and knees again are flexed, with the thumbs on the medial aspect of the baby's knee, while the index finger is placed over the greater trochanter. Upon gentle abduction of the hip, push upward with the index finger and push toward the bed, and laterally with the thumb. Finally, examine the baby's spine. Make sure there is no scoliosis by running a finger down the back. Spinal dysraphisms, such as tufts, lipomas, hemangiomas, large dimples above the gluteal crease, and anal verge, need to be ruled out. Neurologic exam. The neurologic examination consists of a general screen as well as some reflexes that are specific to newborns. Observe the posture of the infant while lying supine. There should be flexion at the hips, knees, and elbows. In infants with hypotonia, the baby often assumes a frog leg position, where the hips are abducted with thighs resting on the bed. The level of alertness can be tested by tactile stimulation of the foot or cheek. The baby should awaken. Tone is best assessed by suspending the infant in a ventral position. In a baby with normal tone, the back should show some resistance to gravity. Lastly, primitive reflexes should be elicited. These include the plantar reflex, sucking reflex, Moro reflex, Gallant reflex, as well as the grasp reflexes. Conclusion. Routine physical examination takes only a few minutes and should be carried out in all infants at the earliest possible moment after birth, just before discharge from hospital, and at regular intervals throughout the first few months of life. Routine physical examination excludes obvious abnormalities and helps make possible an earlier diagnosis of many not quite so obvious conditions.
Let's now move on to the neurodevelopmental examination of the newborn, which should cover evaluation of posture, state of wakefulness, tone, reflexes, higher function, and special senses. A normal posture of a term newborn would be a flexion of both upper and lower extremities with adduction of the extremities towards the trunk. We can observe a frog leg position in the extremely premature or the hypotonic or floppy infant. A healthy newborn demonstrates various states of wakefulness depending on eye opening, respiratory efforts, spontaneous movements, and vocalizations. In deep sleep, you can observe no movement and regular breathing. In light sleep, they have some eye movement with hypotonia and irregular breathing. In a quiet, awake state, the eyes remain closed or half open with slight activity. When the baby is fully awake, the eyes are open and the baby is alert with some movement. The baby can then move on to a fully awake state with plenty of movement, and lastly, a fully awake state with crying. We can assess these states of wakefulness by observation or by parental report, while observing the latching on process is also a good way to observe the state of wakefulness. Unsimulated crying is infrequent in the first 24 hours, and excessive inconsolable crying suggests irritability. We can utilize various maneuvers to assess tone. For example, we assess passive tone using vertical suspension and horizontal suspension. The pull-to-sit maneuver is a good way to assess active tone. And we also can check for ankle clonus, and if more than 10 beats, this is probably not normal. The following video will show how to perform vertical suspension.
Now we're going to put him in vertical suspension. And again, I should be able to hold on to him and have strength in the shoulder girdle so he doesn't just float through my fingers. So that's good. Okay.
Evaluation of posture is also included in the assessment of tone, and we can also evaluate the passive flexor tone, which develops earlier than active extensor tone, usually in a caudocephalic direction. These are generally resistant to intrauterine events or insults and are the basis for the neuromuscular maneuvers included in the Ballard exam, which is discussed thoroughly in your self-instructional material. The neuro exam will include testing for your deep tendon reflexes, and in the neonate, the most reliable would be the patellar deep tendon reflex. The following video will show how to elicit the truncal incurvation.
One other reflex we're going to do is the gallant, which is the incurvation. It's just stimulating one side of the trunk, and the trunk should go towards the stimulus. We're going through the shirt here, which oftentimes is, there we go, and the buttocks or the body moves towards the stimulus. Here's a good strong one on this side.
Part of our neurologic exam is to check for primitive reflexes. These are mediated by the brainstem and spinal cord and are stereotypical. They may appear less brisk in the sleepy or recently born infant, and we assess the presence or absence of these reflexes, and very important to note symmetry, completeness, and persistence. The following videos will show how to elicit some of these reflexes.
Now the last thing I'm going to do with our little friend who doesn't like me anymore, and I don't blame her, I'm going to check for 3 reflexes. First, she is being very nice about it and shows me what we call the grasp reflex. She is grasping with her fingers on my thumbs. And then I'm going to pull, and she is showing us what we call traction reflex. She is flexing her arms. And then the last thing I'm going to do is the so-called moro or startle reflex. So I need to make her startle a little bit, and I do that by pulling the arms out, but I never pull the head off the table, okay? I don't want her to clunk her head on the table. So we go like this, and I let go suddenly. And there she goes, and she shows us a very nice startle reflex.
Put his head in midline. Okay. Move both sides. He wants to turn a little bit this way. Put him this way. And we get into somewhat of an asymmetric tonic nick. We can see this hand extended and this leg extended and the other side flexed. But he can overcome that. He's not obligate. We go over this way. Turn your head this way. And again, we should see he doesn't like that much. This head extend and this foot extend, and this side flex over here. Okay, that's an asymmetric tonic nick. Coming back over here again, and oftentimes we'll see the side where the head is turned towards an extension as far as the leg and the hand, and the other side in flexion, but he doesn't get stuck in that, and he shouldn't be. He should be able to get out of it.
Many of these reflexes are utilized by the newborn to aid in breastfeeding. For example, the feeding reflexes such as rooting, sucking, and swallowing, the protective reflexes including coughing and gagging, or vomiting and biting, and motor reflexes such as writing, placing, stepping, crawling, the moro, tonic neck, and grasp reflex. The following video is an exercise for you to try to observe how these reflexes can aid and equip the newborn to breastfeed.
Por instinto, sé que el único alimento que necesito es la leche materna, alimento que solo con ella los primeros 6 meses de mi vida. Cuido y salvo de la alimentación. Así.
Let's now discuss the special senses in the newborn. For vision, the newborn is capable of brief fixation and limited tracking. They are capable of distinguishing dark and light contrasts, with a preference for circles such as the areola of the breast and the human face. They have some defenses versus excessive demands on the immature physiologic system. For example, exposure to a bright light would initiate an increase in heart rate and respiratory rate, as well as some EEG changes, then blinking, pupillary constriction, and eventually habituation if the bright light persists. The newborn also has specific and well-organized responses especially to the range of human speech, which is in the 500 to 900 hertz. Neonates are more responsive to high-pitched female voices, and they can also habituate to a intrusive sound. The newborn is equipped to adapt to his or her new world and responds to the smell of amniotic fluid and breast milk, especially of his or her own mother, with the sucking pattern changing from bursts with frequent pauses at regular intervals. Newborns are easily offended by the odors of acetic acid or alcohol. Newborns will respond to handling and containment or swaddling by becoming calm or falling asleep. Let's now discuss normal infant feeding behavior. A newborn's behavior in the first week is quite different to the later weeks as breastfeeding is established. Useful caveat is normal behavior in babies indicates adequate breast milk intake. The baby regulates the amount of milk the mother makes because the more milk is removed from the breast, the more the breast makes milk. If the newborn takes what he or she needs, then the mother will make enough milk. If the baby is behaving normally, we are able to reassure the mother that she can continue to feed exclusively. So what is normal behavior in the first week? The first surprise to many is the tiny amount a newborn requires in the first few days. The quantity of milk produced according to day of life and average physiological size of the baby's stomach is illustrated by these three balls. The average amount of colostrum a baby takes at a feed would fill perhaps the middle-sized ball on day 1 if a baby has 5 to 6 feedings a day. However, most babies feed more often than this, so it is more like the smaller marble on the first day, and this gradually increases as the milk supply increases to the golf ball size, and then baby stomach gradually stretches with each increase in amount. So on day 1, the baby's stomach size would approximate the small marble on your leftmost, and that would accommodate around just a teaspoon of breast milk, around 5 to 7 mLs. By day 3, the stomach can accommodate more volume, around 22 to 27 mLs, the middle ball. And by day 10, the stomach can accommodate around 60 to 81 ml. And this coincides with the breast milk production of the mother. So what is the milk like in the first few days? There is only a small visible amounts of colostrum when the mothers are asked to do hand expression of their breast milk. So this photo shows actually more than what most women would get when first expressing, and the milk here is transitional milk as the milk is already coming in. So this is more likely to be already more than 48 hours since the baby was born for the milk to be this yellow color. Colostrum is usually thicker and clearer and can be colored with an orange tinge or even green and still be normal. It is colored by the mother's diet. The baby would get more when sucking at the breast effectively. Okay, let's look at this slide. Which baby is ready to feed? If you answered baby letter D, when the baby is already crying, then that baby is already showing late hunger cues. The baby is already very, very hungry and very mad, and you may have to spend some time calming the baby before he or she is able to feed. The goal is to initiate breastfeeding when the baby is showing early cues of hunger. These early feeding cues are often missed, and the baby may go back to sleep, especially if wrapped, as it is difficult for them to raise hands to their own mouth. Okay, so baby letter A is showing these early cues. The first of which is a change in the state of wakefulness from deep or light sleep to a quiet awake state. And the baby's already sucking on his own hand. And these are early cues that is saying that the baby is hungry, and this is the best time to feed the baby when the baby is showing early cues. The baby in letter B is already more awake, and already the hands are moving with more movement. C, the baby's already wide awake with movement. And D is again a late sign of hunger, crying. So we routinely advise parents not to wait for the baby to cry, but to respond to the early feeding cues. Baby letter E is a baby who is sleeping and full. So I am not hungry. So when a baby falls asleep at the breast after a feed, then that's the sign of satiety. Remember, the more the baby feeds, the more milk the mother makes. So when they respond early to the feeding cues, to the hunger cues, they tend to feed more frequently. This study shows that all babies have more than 6 feeds in 24 hours in the first week. The average number of feeds is between 8 to 10 feeds. On day 2, note that an infant could have as few as 6 feeds, but also over 12 feeds, and it varies with each day. There is often a feeding frenzy just before the milk comes in between 48 and 72 hours of life. Feeding frequently is normal and beneficial before the milk volume increases dramatically, and more feeding will occur at night. This feeding frequently is priming the breast for making more milk later on. Assessing baby during the first week includes looking at the whole baby, review the overall baby behavior, and ask if the baby is waking for feeds. Check the overall tone and temperament. A sleepy, lethargic baby is often unable to suck effectively and may not be getting enough milk. This may not be because the mother does not have enough milk, but because the baby is not sucking effectively or may not be attaching well. A vigorous baby who is wanting to feed is usually a very good sign. Looking at the diaper is an essential part of assessment of the newborn. Let's now look at the stools. It's one of the more reliable signs that the baby is getting milk. Within the first 24 hours, the term newborn should pass the first stool, which is the sticky green-black stool, which we call the meconium, and that changes to a softer green-black color on day 2, and progressively becomes less sticky and shifts in color to greenish-brown as each day passes, and by day 4 to 5 changes to the yellow mustard color of breast milk stools. It's common to have stools 2 to 3 times per hour to every feed in the early weeks. Let's now discuss urine output. 1 wet diaper per day is normal, and some parents will inform you or ask you about an orange-colored stain in the diaper. This is caused by urate crystals reacting to the diaper. This is very common, especially just before the milk comes in. So it's considered normal up to 96 hours of life. Gradually, as the milk volume increases, the urine output also increases to around 6 or more wet nappies per 24 hours by the 5th or 6th day of life. Again, the stools are actually a more reliable sign of adequate intake for the newborn compared to counting wet nappies. Measurement of the newborn's weight on follow-up is routine. It is normal for newborns to lose some weight in the first 3 to 5 days. We call this the physiologic weight loss of newborns, and this is due to the combination of insensible water losses and the normal, relatively low volume of breast milk consumed during the first few days. 7% is the average loss, and greater than 10% of the birth weight indicates an assessment of feeding is necessary. Most newborns should be back to their birth weight by 2 to 3 weeks of age. Lastly, as part of our evaluation, we also ask if the mother notices any breast changes. Feeling a fullness in the breast is a good sign of milk coming in. And the mother should be encouraged to continue to feed often and ensure good attachment and suckling. In summary, we've defined the newborn period and we've discussed the following. Important changes during the transition period from in utero to extrauterine existence, the immediate needs and care of the newborn, how to go about the history and the physical examination of the newborn, including the neurodevelopmental exam, with emphasis on the capability of the newborn for breastfeeding, and how to evaluate normal infant feeding behavior. The United Nations Convention on the Rights of the Child states that every child has the right to enjoy the highest attainable standard of health. It is the right of every newborn to be provided its immediate needs in the first minute, the first hour of life, and so forth. The highest attainable standard for newborn feeding is breastfeeding. And to build your knowledge on this crucial intervention, you will have another separate lecture on breastfeeding as part of this module. And just to remind everyone, we as healthcare professionals should not request nor accept any of the following from milk companies or their representatives. So any gifts or samples, posters, promotional materials, or direct promotions of products covered under the milk code, that includes sponsorships, etc., as all these seriously undermine our provision of best care for newborns, which is exclusive breastfeeding. Thank you, and I hope you continue to enjoy this module.